we are both in the same business, which is protecting the brain. In fact, that's probably the goal of all of medicine, to protect the brain. So I'll tell you my perspective on it and look forward to hearing your perspective on it. Here are my disclosures. And to get us started, let's imagine a case, a fairly typical one that I think both of us all of us deal with on a regular basis. Imagine a 70-year-old patient with atrial fibrillation who develops an acute left hemiparesis, probably from an MCA occlusion. He has atrial fibrillation, but like so many patients with atrial fibrillation on warfarin, his INR is not therapeutic. In the United States, that's the case about 45% of the time, that patients who take warfarin are not in the therapeutic range, most often too low, where they're totally unprotected from a stroke, as opposed to too high, where their risk of hemorrhage goes up only slowly. This particular patient is lucky that he had symptom onset only about 90 minutes ago, comes to the emergency room, gets a CAT scan, has no other contraindications, and is treated with intravenous TPA. And after 4 or 5 days on the stroke unit, getting the usual testing, making sure he doesn't need a carotid endarterectomy, we are faced with the decision of how to prevent more events, knowing that having one ischemic stroke puts him at extremely high risk for having another. In fact, it's the most important risk factor, other than age, for going on to have a further stroke. A few other details, some of which are relevant and some of which actually are not, to our choice of anticoagulation. He's 70 years old. That is, of course, important. He has paroxysmal AFib. To a first approximation, AFib is AFib, whether it's paroxysmal or permanent or chronic. He's got high blood pressure and diabetes, also adding to his stroke risk. His INR is said to be labile. This is true of almost everyone on warfarin. The average time in therapeutic range in the United States is only about 55%. In the best warfarin clinics, dedicated anticoagulation clinics, we can do a little bit better, but still rarely beating 60 or 62% time in therapeutic range. So labile INR is more the rule rather than the exception. Importantly, for our choice of a blood thinner, his creatinine clearance is almost 60, which puts him in the range of a relatively normal kidney function. And he's been on the stroke unit a few days, not being anticoagulated. That's our practice in acute stroke. We usually hold off for a few days, let the dust settle, make sure the patient doesn't need a feeding tube, doesn't need surgery on a carotid, and then after a few days, restart anticoagulation. So what is our priority when we're thinking about how to restart an anticoagulant, especially in somebody like this with multiple risk factors: age, high blood pressure, diabetes, and most importantly, a recent TIA or non-disabling stroke? And I think we as physicians have a lot of things on our mind, but patients really only have one thing on their mind, and that is they do not want to have another stroke. In fact, if you ask your patients, what are you most afraid of, they might give you an answer that is different from what you're most afraid of. You might say you're concerned about compliance, you're worried about GI bleeding, you're worried about falls. They're worried about having another stroke. They, in fact, are more worried about having a disabling stroke than they are about dying or bleeding or having cancer or any of the other things that happen to older people. They are more worried about having a stroke than dying. And the strokes that older folks have in mind when they tell you that they're more concerned about having a stroke than dying are the typical atrial fibrillation-related strokes, hemispheric blowouts that render patients, especially older ones, in a nursing home, bedbound, dependent on other people for their basic bodily needs. They would rather die than have this, and they would certainly take a bleeding risk rather than have a risk of that kind of stroke. And so that, when I choose an anticoagulant, is my number one priority, preventing a stroke. The one thing, although patients may not know this, the one thing worse than a cardioembolic ischemic stroke is an anticoagulant-associated brain hemorrhage. We'll talk about in a few minutes about how bad those truly are. But both of those cerebral events are the things that we want to prevent, I think, more than anything else. What are the guidelines? What do societies like the Israel Heart Society or the American Heart Association tell us to do with patients who have atrial fibrillation at high risk of stroke, and especially for those in whom we're practicing secondary prevention? Well, they tell us that these are patients that need long-term anticoagulation. And when you look at the choice of agents, they give class 1 recommendations to warfarin, apixaban, and dabigatran, and a lower class 2 recommendation to rivaroxaban. You might ask, given the data that I know all of you know about the superiority of dabigatran and apixaban over warfarin, how is it that warfarin therapy also gets a class 1 recommendation when we have 2 agents listed below vitamin K antagonists that beat warfarin? I think the answer to that is more political than scientific. The main goal of all of these guidelines is to get patients on some anticoagulation. In the United States, about half of people who should be taking a blood thinner for stroke prevention and AFib aren't on anything. And warfarin, being inexpensive and having a long track record, although it's a difficult drug to take, is certainly better than nothing. And so that's what leads it to get a class 1 recommendation along with dabigatran and apixaban. But I think if you look at the scientific data, as we'll talk about, probably the class 1 recommendation behind the 2 novel agents is a stronger class 1 recommendation than the one behind warfarin, or at least it probably should be. Now, what about leaving this patient on warfarin? One could make an argument that he had a stroke, but his INR was below 2, and so he wasn't a biological warfarin failure. He was more of a logistical warfarin failure. In my view, a logistical failure is a failure of this therapy. We know that warfarin is a difficult drug to take. We know that it's a rare patient who can stay therapeutic most of the time. And so I think warfarin would not be the first choice. In fact, I'll go further and say that even had this patient not been on a blood thinner, had he not failed warfarin, I still don't think of warfarin as a first choice unless there is some reason like severe advanced kidney disease that they really can't take a novel anticoagulant. So the novel agents have become my first line therapy. What are the reasons I like NOACs? Well, number one, the twice-a-day NOACs, apixaban and dabigatran, are better at preventing total stroke than is warfarin. That's really no doubt about that data. They are all safer for the brain in terms of not leading to an increased risk of intracerebral hemorrhage compared to warfarin, significantly decreased risk. It's good to have a reversal agent, and as I'm sure you're all aware, dabigatran has a reversal agent that is newly approved in the United States, and I suspect is in regulatory consideration here in Israel and available in clinical trials at a number of sites throughout Israel for people who have emergent bleeding. They're all easy to use compared to warfarin. They have no food interactions and in general no important drug interactions. And so that makes taking them much easier. And of course, routine monitoring is not needed, also not possible. The NOACs as a class are better than warfarin at preventing stroke and systemic embolism. That data is shown in aggregate here. You can see that in aggregate, there is an advantage for total stroke. Systemic embolism is such a small risk in these patients that when you see stroke and systemic embolism, it really means stroke. Systemic embolism is only about 5% of embolic events. There's an advantage of warfarin driven really by dabigatran and apixaban and not so much by rivaroxaban. A large advantage in terms of hemorrhagic stroke safety, and that actually is driven by all 3 agents, but more by dabigatran and apixaban. So that's why I like the NOACs in general, but how do we differentiate them among the novel agents? There are three criteria by which I think we can make this differentiation or judge these agents, keeping in mind that they really have not been directly compared in clinical trials to each other. So we're forced to look at how they compare to warfarin in clinical trials and make inferences based on that indirect comparison. Number one, we want to prevent total stroke and systemic embolism, and both dabigatran 150 BID and apixaban dosed in the usual way both beat warfarin for preventing total stroke and systemic embolism. We want to specifically prevent ischemic stroke while not leading to an increase in brain hemorrhage. Dabigatran 150 BID is the only one of the novel agents to have beat warfarin for preventing ischemic stroke. And that is, in my view, a major finding. I heard when this business started from Mike Ezekowitz a statistic that warfarin for preventing ischemic stroke in somebody with atrial fibrillation is the single most effective preventive therapy in all of adult medicine, not just in neurology or not just in cardiology, but in all of adult medicine. Nothing else really comes close to the 65 to 80% relative risk reduction for stroke that we get with warfarin, and yet dabigatran 150 BID beat this incredibly effective but somewhat cumbersome therapy. And then we also don't want to cause an excess increase in intracerebral hemorrhage, and all of the novel agents are safer for the brain in terms of bleeding than is warfarin. But you see from this diagram that compared to warfarin, the only one that meets all three of these criteria is dabigatran 150 BID. 24% relative risk reduction for preventing ischemic stroke compared to warfarin, and that's warfarin with a 64% time in the therapeutic range with an INR between 2 and 3, and a 75% reduction in intracerebral hemorrhage. I think it's easy for people who are not stroke specialists to underestimate the importance of this reduction in intracerebral hemorrhage. Yesterday, we talked a little bit about a conversation I had with a colleague of mine who's a cardiac electrophysiologist at Northwestern who sees a lot more atrial fibrillation than I do. He does ablations, he puts people on antiarrhythmics. He really does almost nothing but atrial fibrillation. And yet he told me that he doesn't see patients with warfarin brain hemorrhages. And he asked me if that was even a real phenomenon or was it something that we just read about and never actually see. And I was shocked by that question since I see on almost a monthly basis a couple of people who have horrible brain hemorrhages from warfarin. And I realized the reason he doesn't see these people is that they have an 80% chance of being dead or permanently disabled after bleeding in the brain on warfarin. And the last person they need is a cardiac electrophysiologist after that happens. They meet me in the neuro ICU. More often than not, their next stop is the grave, and if they survive, they go to a nursing home, almost entirely. And so these people end up off the radar. They end up off the radar medically. Even worse than that, they end up off the radar socially when they survive, isolated in a nursing home, not looked after 24/7 by either a family member or a staff member. And so to reduce ischemic stroke and have this huge reduction in the worst complication of this therapy is really nothing short of, I hate to use the word a miracle in Israel, but almost nothing short of scientifically miraculous. Now, what about the issue of twice a day versus once a day dosing? I hear this a lot, and I have to tell you, I think it's almost an inappropriate consideration when you're trying to prevent stroke. And the reason I think that is patients with atrial fibrillation, especially the more elderly ones who have high blood pressure, who have had a stroke, who have diabetes, they are taking medications twice a day. There is no reason that they can't take an additional medication twice a day. And at least the best-selling once-a-day medication has to be taken with a large meal, which is not a time that patients are taking their more routine medications. Furthermore, I think if a patient told me, and if they can tell me anything for a stroke patient, that's a step in the right direction. If they tell me they really don't want to take something twice a day, I'll ask them, were they paying attention to the fact that they just had a TIA or stroke? That is a lot more inconvenient than taking a medication twice a day. The one exception to this way of thinking, in my view, is somebody who is totally dependent upon a caregiver for their medications, somebody who's severely disabled. There, I think anything we can do to make the caregiver's life easier, including a once-a-day medication, probably is reasonable. These are patients often in whom convenience should predominate over effectiveness because they're usually wrecked to begin with. But barring that particular circumstance, I don't see a problem with giving a medication twice a day. And that is especially true with the NOACs, all of which have a half-life of about 12 hours. And basic pharmacokinetics says that drugs with a half-life of 12 hours generally should be given twice a day. This slide shows what happens if you miss a single dose of a once-a-day medication. Shown in blue, you end up with a very low drug level with a single missed dose, whereas a single missed dose of a BID medication, you end up still not getting too low before the next dose gets you back therapeutic. So I don't think the once-a-day issue is terribly important. If you look at the data behind dabigatran, now in the 20% of patients in the RELY study that had a history of TIA or stroke, you can see that both the 150 milligram dose, which is the only proven dose that we have in the United States, and the 110 milligram dose, which I know you have here, are both effective compared to warfarin for preventing now recurrent stroke, since this is the secondary prevention population. Now, when dabigatran came out in the United States, it was the first of the novel anticoagulants to hit the market, and I think there were a number of perceived problems with the drug. I say perceived rather than real because the problems were that there were some patients with GI bleeding, there were some patients with traumatic bleeding, with falls, and people expressed all this shock that there could be bleeding with this novel anticoagulant. I personally don't know what they were expecting. It's a blood thinner, and while it's better than warfarin, it's still a blood thinner, and all blood thinners, including aspirin, carry with them a risk of bleeding. But nevertheless, people expressed surprise, and this led the FDA and other government agencies in the US to do some real-world studies on dabigatran to see if the results in general real-world practice were equivalent to what was seen in the clinical trials. In other words, to make sure that doctors were using the drug correctly, and when used according to the FDA label, were getting results that could reasonably be predicted by the clinical trials that led to the drug's approval. And this is the largest of those studies. What they did was take about 130,000 Medicare patients, so these are patients under our government healthcare system, generally over 65, and they compared 65,000 or so new starts on warfarin to 65,000 new starts on dabigatran for atrial fibrillation. They were propensity matched, meaning their risk factors for stroke and for bleeding and for all the other bad things that happen to these patients were roughly equivalent, allowing a direct comparison. And they compared the risks of ischemic stroke, bleeding in the brain, bleeding elsewhere, GI bleeding, MI, and death in the Medicare population, the real-world population, to the population that was studied in the RELY trial. And what they found was I think, an amazing reproduction of the RELY results in this real-world population. So shown on the slide in the top panel are the results from RELY, and in the bottom panel are the results from the Medicare real-world analysis. And it's incredible how there is almost perfect mirror symmetry along this horizontal axis. So just like in RELY, in the Medicare population, there were fewer ischemic strokes with dabigatran than with warfarin. There were dramatically fewer intracerebral hemorrhages with dabigatran than warfarin, just like in RELY. Major bleeding, about equivalent. GI bleeding, there was an increase in major GI bleeding with dabigatran than warfarin. This is exactly what was seen in RELY. This is the bad news from the RELY trial, and I think it's reassuring from a scientific perspective that that same bad news was also seen in real life, telling us that these results are scientifically valid. MI, no signal at all of an increase, unlike the RELY trial, and mortality, a decrease in favor of dabigatran over warfarin. And so this real-world study reinforces the scientific validity of the pivotal RELY trial. So returning to this patient, this is an elderly man, recent stroke, high blood pressure, diabetes, in other words, very, very high risk for more brain ischemia, good creatinine clearance. That's a key consideration because dabigatran is about 75% renally excreted. In somebody who has poor renal function, this is probably not the best drug, but this patient has a creatinine clearance that's well within normal range for his age. This is somebody I would put on dabigatran 150 milligrams BID, putting a primacy on preventing ischemic stroke and not putting his brain at excess risk for bleeding. What if this patient had failed rivaroxaban? I personally don't think that changes the consideration because even had he not failed rivaroxaban, dabigatran would be my first choice in this type of patient. But there are some guidelines based really on indirect comparisons put out by the European Society of Cardiology, recommending that in people who have ischemic stroke, despite taking rivaroxaban or apixaban, due to the improved stroke prevention compared to warfarin that was seen with dabigatran, they suggest switching the patient to dabigatran. This is I would say, a suggestion rather than a hard and fast evidence-based recommendation, but it does make sense. I think it does make some sense. Finally, I mentioned earlier that there is a reversal agent on the way. It is literally on the way in the trucks to the emergency rooms in the United States. I hope it will be on the way to your hospitals soon, and that is Praxbind. Praxbind, or idarucizumab, is a monoclonal antibody fragment against dabigatran. It binds to dabigatran about 350 times more strongly than dabigatran binds to thrombin. And so when you give it to a patient intravenously, it instantly binds all of the dabigatran, both protein bound and bound to thrombin, and even distributed in peripheral tissues, binds it, inactivates it, and then the complex is excreted over the course of 5 or 6 hours by the kidneys. And let me show you some data from the REVERSE-AD trial. This is a trial that is still ongoing. We expect to enroll about 500 patients. We've got about 330 enrolled as of this moment. And this is a study in which patients who are taking dabigatran are treated with this antidote, single arm, so everybody gets treated with 5 grams for one of 2 indications. Population A is population that's having life-threatening bleeding, where the risks of reversal are judged to be the bleeding is judged to be so severe that the risks of reversal are worth taking. This would be people with bleeds that are leaving them hemodynamically compromised or requiring major transfusions, or any bleeding in the brain by definition is worth reversing because of the risk of hematoma expansion. And then the second population is a group of patients taking Pradaxa who aren't bleeding but need emergency surgery that can't wait 8 hours. Broken hips, heart surgery, retroperitoneal, any surgery that cannot wait, is population B. And the endpoint in this trial is reversal of the dabigatran coagulopathy as measured in one of two ways, the Eckermann clotting time or the dilute thrombin time. And here is data from the first 90 patients that was published in the New England Journal of Medicine a few months ago. And you can see that using the Eckermann clotting time, a very specific assay for dabigatran coagulopathy, at the time the patients roll into the emergency room, there's a wide range of abnormal dabigatran activity. Patients are given 2 half doses, so a total of 5 grams of Praxbind. And even after the first half dose, there is almost complete reversion to normal on the Eckermann clotting time. More than 9 out of 10 patients went to normal with the first dose and remained that way, with only a handful of patients who had taken massive overdoses of the drug creeping up at 24 hours. Now, we don't have the Eckermann clotting time available for us for routine clinical use. So one of the things we did in the study is also look at the PTT, which is, of course, easily available within a few minutes in emergency rooms. And what we found is that the PTT tracks precisely with the Eckermann clotting time, telling us, number one, that in an emergency we can use the PTT as a qualitative measure of whether or not somebody is anticoagulated with dabigatran, not a quantitative measure. And number two, that we'll be able to use the PTT as a marker for whether or not the Praxbind has worked. So I think there's really no doubt from this data and from the other details that are in the paper that the drug does what it's paid to do. Whether or not it improves outcome is a separate issue and one that's hard to study, because patients taking blood thinners bleed for all sorts of reasons. They have trauma, they have holes in their arteries in various places, they have intracerebral hemorrhages. Their outcomes are dictated by a lot of things besides their coagulopathy. So the goal of using this drug is to take the dabigatran out of the equation and let you focus on stopping the bleeding by whatever means are necessary. The Praxbind itself is not going to plug a hole in an artery, but it does remove at least this one significant variable from the equation. So to summarize, and then I'd be happy to take any questions you have. Number one, when a patient has had a stroke or TIA and they have atrial fibrillation, our main priority is to prevent a recurrent ischemic stroke without leading to an excess of intracerebral hemorrhage. All of the NOACs have some advantages over warfarin. Dabigatran in particular is the only one that has data showing it is better than warfarin at preventing ischemic stroke. And the convenience issue of once a day versus twice a day is not, in my view, a significant consideration in most patients.